So Dr. Sharon Bober is our first presenter, and Dr. Bober is an institute psychologist at the Dana-Farber Cancer Institute, an associate professor in the Department of Psychiatry at Harvard Medical School. She is the founding director of the Dana-Farber Sexual Health Program and the program psychologist within the Division of Cancer Genetics and Prevention. Dr. Bober's research interests center on sexual health, cancer risk, cancer survivorship, and quality of life. And then we also have Dr. Chung. Dr. Chung is the associate professor of urology at the Sidney Kimmel Medical College of Thomas Jefferson University in Philadelphia. He obtained his medical degree at Thomas Jefferson University and subsequently completed general surgery and urology residency training at the University of Texas Southwestern Medical School. He completed a research fellowship at the Urological Oncology branch of the National Institutes of Health and a clinical fellowship in urological trauma reconstruction and prosthetics at the University of Washington Medical Center. He has a lot of other big words after that, but he told me I don't have to read all of them, so I'm going to let him talk. But please join me in welcoming Dr. Sharon Bober.
Thank you. It's a pleasure to be here with all of you today. I'm not going to make the menopause joke because it's like freezing cold and blah, 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 but I'm freezing cold, so hopefully they'll hand out blankets in a few minutes and we'll be okay. This is my disclaimer. I really just want to acknowledge that, I appreciate that there are many different gender identities and pronouns that people use. I will be using pronouns often reflecting data about cisgender women, but I get that. I also just want to say that when it comes to sexual health, I really want to clarify that this is really health, right? And I appreciate what you said, Rebecca, about being brave to walk in the door. I didn't know if you were meaning like any door or about this door in particular, but I would say this door in particular is no different than any other door, right? And I think part of the issues that we all struggle with sometimes is that sexual health has still so much taboo and stigma, but really my perspective around this is that this is really no different than any other aspect of health, and we really need to think about it in that way. And the reality is for most people, it often becomes like, the elephant in the room, because actually we don't do that, right? This is not sort of standard part of survivorship care or previvors care for lots of folks, or people may hear like a little piece of something, but not really a whole lot about sexuality and sexual health as a whole. There are lots of reasons as to why that is. There are lots of people who spend time studying that. What are the barriers? What are the challenges as to talking about sexual health? Because the fact is, most folks say that they didn't hear a lot about it. I'm not going to go into a lot of detail, but just to say that from a cultural observation, it's a funny thing. We live in a culture that is truly saturated with sexuality and sexual images, and very little of that has to do with real life and real people, and real sexuality. So, there's also lots of, I think, confusion in terms of the medical context, certainly around who initiates these conversations. When we do surveys with medical providers, they say definitely should come from the patients. When we do surveys with patients, they say it definitely should come from the providers. And honestly, most medical providers get very limited training, right, in sexual health. And often it's complicated, right, to go down a road to talk about something that, maybe someone doesn't feel totally sure about what to say. So, the bottom line is that I'm going to take the perspective here today that sexual health is really at the intersection, right? It is at the intersection of physiology, of mental, cognitive health, of how we think about ourselves, of relationships, of all the interpersonal stuff that happens, of motivation, and throw in a big dose of sociocultural sort of context in that as well. Everyone comes to this in a particular context, in a particular culture, and that we often, in the same way that changes may often be at the intersection of many of these dynamics, many of these components, often the road ahead in terms of recovery means figuring out what are these pieces that need to be put back together. So again, in terms of sexuality and well-being, I will just say that there are lots of reasons why it makes sense to be thinking about sexual health, partly because it's good for us, right, in terms of emotional and physical health and well-being, and that there's really a wide range of normal. That's the other sort of starting point assumption, which is that, what we know is that sexuality is part of the sort of the human experience across the lifespan, and that there's actually a very wide and varied range of normal. Things mean differently to different people, but I really want to underscore the point that if there is something bothersome or distressing for you, if there's something that you're worried about or a change that's bothersome for you, then it's worthy of attention. So the fact is, every type of treatment that we bring to bear to address cancer or cancer risk has the potential to disrupt sexuality and intimacy. That's the truth. We also know that there are very many common changes. I'm not going to speak in great detail about every one, but thinking about the overview, I'm very aware that my friend and colleague next door is speaking about menopause and hormone management. We just had a conversation outside saying, wait, we should be at each other's and they're all the same and everybody should be at both. So I promise you I'll be making sure this does not happen again, that these talks are given at the same time, at least as far as I can advocate. And write that in your review, or when you write your recommendations, if that was important to you, I would actually say, does it make sense to put the sexual health and the menopause management at the same time? Okay, that was my side comment. But, genitourinary symptoms of menopause. So these are basically we think about what menopause is, right? Loss of estrogen. Symptoms are essentially clustered into two main domains, what we call vasomotor symptoms, hot flashes, night flashes, and what we call the genitourinary symptoms of menopause. Loss of lubrication, arousal changes, that kind of thing. Super common. We also think about what that means in terms of decreased desire, loss of sexual activity, less sexual activity, loss of satisfaction broadly, body image distress. We all know what that means, and we're not just talking about what bodies look like, but what that means to be in your body and feel comfortable and feel strong and feel a sense of integrity versus all the ways that we can be in our bodies but often feel sort of detached or alienated or uncomfortable. We also know that there are relationship stressors that go along with this stuff. That may be that there are role changes. It's hard to talk about dating after all of this. How do you start? How do you reconnect with a partner after it's been months or years of time where things are different? So that's something that we need to think about. And obviously all of that's distressing, right? That's not a small thing. So I want to just sort of think about what are some common next steps. I want everybody to really kind of come with me on this journey, that I'm not assuming that everything I talk about is relevant to everybody in this room, but I'd invite you to really sort of think about what pieces you hear that may be relevant for you and maybe what you might take with this as a kind of a next step for what you might want to do or who you might want to talk to if you need some support. So I always start with talking about vaginal health, and the reason is because in many ways, when we talk about sexual health, we also talk about vaginal health. They are not the same thing. I really want to be clear about that, but they're obviously one, related, and two, if there are changes in vaginal health and genitourinary symptoms of menopause that are not addressed adequately, it's going to be a problem as we move down the chain, okay? So in terms of thinking about vaginal health, and again, I think this is critically important, whether you are sexually active, whether you are partnered, whether you're sexually active with someone else or by yourself, it doesn't matter. If you, I would say, have a vagina, and this is something every woman needs to be sort of aware of, okay? So thinking about what that means in terms of estrogen loss, estrogen depletion, and menopause, when it comes to vaginal health, we're really thinking about very common changes that have to do with loss of moisture, loss of stretch, and loss of blood flow to that tissue, right? So what can happen when those things happen, we have not just loss of lubrication and elasticity, but that can mean that intercourse hurts, that can mean that sexual activity is less comfortable. We know that when we lose ovarian function, we lose about half of our testosterone, and there can also be urinary symptoms, right, that go along with these changes. And I mention that again because thinking about sexuality more broadly and what that means to feel comfortable in oneself and sexual health, that also means addressing these issues if that's something that is bothersome, okay? So I would just say that, It's really important to be aware of how to restore vaginal health if that's something that's been disrupted or you're concerned about something in that domain. Very quickly, I'm going to go over a couple of basics that I think everyone needs to be aware of. When we talk about managing vaginal dryness, everybody hears, use a lubricant, have a glass of wine, relax, use a lubricant. Not adequate, okay? Just to be very clear. There is a class of products that are called vaginal moisturizers, different than vaginal lubricant. Lubricant's kind of something that keeps reduces friction and stays on the surface. Moisturizer is something that holds water in the tissue. Anyone put moisturizer on their face before they go to bed at night? Very common. I would say that, if you're moisturizing your face before you go to bed at night, you maybe need to think about moisturizing your vagina, right, as part of it. That is not something that everyone sort of talks about commonly, but it's just part of basic, I would say, vaginal health post-menopause, whether that is early menopause, whether that is menopause that is regular, whether that's sort of menopause later in life, doesn't matter. The point is that you need to restore moisture to that tissue on an ongoing basis. That tissue cannot moisturize itself. Okay, so different kinds of products out there, not going to go into a ton of detail. I will just say that the basic distinction is over-the-counter products that are non-hormonal, and then we have hormonal based products. Typically, we talk about local vaginal estrogen or local vaginal DHEA. This is not hormone replacement therapy. This is not hormone that is systemically absorbed. We use this very regularly with women who are previvors, with women who are survivors. There are a number of large cohort studies that came out just in the last couple of years that look at risk of recurrence. Issue is that there's still a black box warning on vaginal estrogen, but vaginal estrogen, the more that we know, the more I think there's a growing consensus that it's actually very safe. Again, not systemically absorbed. Not going to go into a whole lot of detail, but just to say that really important to do something if you're in menopause in terms of that moisturizing piece, okay? And that's a conversation you can have with your team, with your primary care doctor, with your gynecologist, with your oncologist, whoever. But whatever you do, you need to do something. It's not something that you can leave by itself. I will put in a plug for pelvic floor health. This is another piece for anybody who is having concern about, certainly any kind of pain or discomfort with or without sexual activity. Most of the time, women never hear about their pelvic floor unless you've had a baby and people tell you to do those Kegel exercises where it's about squeeze, squeeze, squeeze. That is just the opposite of what we find often post-menopause, where those pelvic floor muscles are what we call hypertonic. They become over-engaged or overly rigidly engaged. That's a problem when it comes to sexual function and sexual activity, and you need those pelvic floor muscles to be relaxed. Most of the time, we don't even have an awareness of what our pelvic floor is doing, and lots of times it's really important to put these pieces together in terms of restoring health and well-being around sexual function. So what does pelvic floor rehab look like? We have lots of strategies that are part of that. There's a kind of a very necessary component about learning how to become aware of and relax those pelvic floor muscles. We do a lot of work to help women restore elasticity to that tissue. If you can see that sort of set of silicone dilators at the top, those are sort of a gradiated set of tapered dilators, which literally you can use sort of systematically to gently increase stretch, right? Those are not vibrators. Those don't actually do anything. They're static. But in a very systematic way, if once for oneself, you're practicing your breathing, your pelvic floor relaxation, you can sort of like any PT gently start to stretch that tissue and get some elasticity back to that tissue. So that's a really important component for women who are having pain or discomfort. We talk a lot about vibration therapy, the need to get good oxygenated blood flow to tissue. I'm sure Dr. Chung will talk about that too, because there's a commonality there. We need good blood flow to that tissue. And I would just say that for anybody who's dealing with pain or discomfort, who's tried using lubricator or moisturizer, and you're still having pain, that's that yellow blinking light that you may need some more additional help. And often some pelvic floor rehabilitation is going to be important. So there are lots of pharmacologic options. As I said, some of those have to do with vaginal estrogen, vaginal DHEA. There are other things that we think about. For example, for insertional pain with intercourse, Sometimes we use some lidocaine, sort of a little bit of a numbing cream around the vestibule. In terms of low desire, I'm not going to go into any real detail about the 2 FDA-approved drugs for low desire. They have really not been tested or validated in folks who have had cancer, and I would just say that the efficacy is not a whole lot better than placebo. So, we could certainly talk about that if you have any more specific questions, but in general, low desire is not best treated with a pill. We really don't have a magic pill for that. And I will just say quickly, lots of times people have heard about the laser. I don't know if people talk about the CO2 laser, Mona Lisa, for what's called vaginal atrophy. I will just say that the couple of randomized controlled trials that have been done with women after cancer did not show that it was superior to sham control, and especially for women who are on any kind of aromatase inhibitor, low estrogen, have really sort of fragile tissue, that CO2 laser may actually be a little bit more harmful than helpful. So just to say that it's not something that we recommend. There are lots of people who have lasers in their office and are selling that product, but that's not something that we would sort of assume or recommend as a first-line kind of thing to do. Okay, so that was my super quick overview about the physical mechanics, but I just want to say that when it comes to sexual health and women's sexuality, it is necessary but not sufficient to often just talk about the physical mechanics. When we think about all of the things that we are thinking and feeling, body image, it's really important to be able to address those other issues in tandem, because often the physical mechanics are critically important, but I would say necessary but not sufficient, right, to address some of the issues. So when it comes to things like body image, I think it's really important to just remind yourself, body image is not driven by a body part. I understand that individuals go through all kinds of body changes, but ultimately when it comes to feeling whole, feeling a sense of integrity in ourselves, it's really not about a part or a piece. It's really about us as a whole person. And I think that we need to think about cultivating a sense of compassion for ourselves. We often go through so much to be able to get to where we are. I think it's important to cultivate a sense of kindness for yourself, and we do this very well for our sisters and our friends and our family in a way that we often don't do for ourselves. And I would say bottom line is around body image, focusing on what your body can do, what your sense of wholeness and strength can be based on function, rather than how something looks from a kind of a visual point of view, is really important. Because we put way too much focus, as we all know, as any woman knows, as anyone who has to go buy a bathing suit in this country, on how, some sort of very slim idea of what visual beauty looks like. And I will just say that when it comes to relationship, when it comes to sexuality with another person, we see each other not by being defined by a piece or a part, but by who we are as a whole. Right? And so being able to really sort of do a piece of work, potentially with a therapist or counselor around that, can be really, really helpful if that's something that people are struggling with. So I think that when it comes to cognition, that awareness of how thoughts and feelings are connected, it's like super duper important. I used to use this thing about like a tape loop, but then my research assistant was like, people don't listen to tapes anymore. You understand that that's like really old, and like, what's a tape? And I was like, wow, yeah. So I was like, okay, you're a young person, what do I do? So she's like, yeah, you need to have it on, whatever that thing is. So anyway, but I know, I'm old, I get that. But I really just want to make the point that we all listen on loop all the time to all kinds of things, right? And that especially when it comes to body image, sexuality, if I'm sexy, if anyone will ever think I'm sexy again, if I'll ever be attractive, what does my partner think? It's like press play and it just goes, right? And I will just say, that's a really big part of often what keeps us feeling sort of stuck in certain ways, and that if that's something that you are aware that you might be dealing with, you may want to get a little bit of support for that, right? There are ways to be able to sort of look at those thoughts and feelings, right? And really be able to challenge those, right? We don't have to be sort of led by them, but we actually may be able to talk back to some of them or ask ourselves, is that actually true? Is that something I would say to a friend? Is there another way to look at it? All the kinds of things that we would do for somebody else, and then we don't might do for ourselves because we just assume that tape loop is actually true, and it may not be, right? So the cognition piece is really very important. And then the other side of that, that's not just about questioning those thoughts, is sometimes sort of taking a mindfulness-based approach to that and recognizing that we have all kinds of thoughts, right? Our brains are sort of like in motion, constantly generating thoughts. Many of them are not true. That's what our brains do. The meditators call this the monkey mind, right? They're just generating thoughts all the time. And being able to sort of have an awareness of that, but bring a kind of a non-judgmental stance where you are sort of aware in the moment of what you're sort of thinking and feeling, and you're not all of a sudden assuming it's true, but you're able to sort of notice it without judging, that's a game changer, right? So sort of just that piece around cognition is really important, and there are really different ways to sort of approach that. I will say I want to take just a minute or two to talk about changes in desire or loss of desire, because this is probably the most common female sexual function complaint, with or without menopause, with or without surgery or cancer involved. There are often many components to this, but one thing which is very important to recognize is that if you are having dryness, discomfort, if you are having painful sexual activity, you can bet your bottom dollar that you're not going to want to have sexual activity, right? And often what happens when that happens is those pelvic floor muscles, remember going back to the pelvic floor, start to clench automatically. There's a name for that. We call that vaginismus, right? Where the pelvic floor is basically saying, you might be up here going, yeah, I'm going to do this, and your pelvic floor is like, yeah, no. Right? And it gets very tight. And so being able to recognize that, when we're having fear or anxiety or worry about that, what is the first thing that we do? Right? I have had so many patients over the years say to me, like, I do everything I can to make sure we don't get in bed at the same time. We don't go to sleep at the same time. I make sure I'm watching TV just to avoid that moment where I'm uncomfortable, right? And the fact is, decreased desire is often a compilation of a lot of different factors, often having a piece to do with avoidance anxiety, right? Because it's uncomfortable, it's hard to talk about, there are things I'm not sure, or I feel guilty, or I feel bad for my partner, I mean, like, how many times do clinic visits start with, my partner has been a saint? I'm like, I know, right? And I feel terrible because I haven't been able to ... Okay? So, that avoidance cycle is also really relevant when it comes to sexual health, right? So when we're in that space and there's something that I feel upset about or worried about, and I have that kind of negative self-talk going about this is never going to get better, this is not what I expected, I wasn't sure how to deal with this, and then I avoid, because in the short term, and this is the most important piece about this, in the short term when we avoid something that's uncomfortable, we feel better. It's like a little bit of a relief. Phew, I don't have to deal with that. That is an incredibly powerful reinforcer, right, when you have that short-term relief. The problem is that when you avoid something and you feel a sense of short-term relief, you keep reinforcing the avoidance piece, and you never get to the real issues. And long-term, anxiety doesn't go down, right? So the thing is, it's very different when we can kind of move beyond avoidance, right, to a place where we're able to accept and tolerate some of that discomfort, enough so that we actually say, wait a minute, I have to think about how I'm talking to myself about this. I have to think about how I'm talking to my partner about this. Maybe there's a different way to think about this, right? What can I actually do that gets me past that avoidance into actually trying something different, right? Into actually doing something different. I may actually have an experience where I have something shifts. I feel better, or that was not what I expected. But that ultimately that will allow you to create a new repertoire and do something different, ultimately achieving your goal, hopefully, right, if that's what you want, to have greater intimacy. But often that avoidance piece is something that we don't articulate, and that's often a very powerful piece that sort of undergirds what's going on in terms of some of the change. So there is no question that there is often some relationship work to be done. I recognize that everybody, people may or may not be partnered, but for folks who are partnered, this is often something that partners have no idea how to talk about, not really sure what to say. Nobody wants to hurt each other. People want to protect each other, right? And often partners really sort of need to create a bit of a new repertoire together to figure out how to refocus on what is pleasurable and what is sensual in a way that is maybe different than you've done it before. Not being goal-oriented around sexuality, right? For most of us, we're creatures of habit. We do what we always do, and that may have a sort of very specific repertoire. Or knowing that, this kind of action or that kind of foreplay always leads to this, so I don't do that because I don't want to go here, right? Like, we sort of have a script. And what would that mean to actually rewrite that script a little bit or do something different? So I think, in summary, from my point of view, a lot of thinking about sexuality in the context of changes you may have had, or changes you may be worried about, or changes that may not have happened, but you want to sort of just be proactive about, we often have to reset the frame a little bit. We often have to acknowledge or accept that there may be things that are different. If people have prophylactic mastectomy and lose nipple sensation, and nipple sensation was really important in terms of having an orgasm or arousal, like, I want to acknowledge that, right? I want to acknowledge that. You need to sort of recognize that there's a loss there, and I want to say that out loud, right? And that's real. And I want to say that that doesn't mean that you're at the end. It just means that the acknowledgement, the acceptance, then allows us to then say, now what? If we move through that, how do we create a next step? What is the next repertoire? What are the other erogenous zones in your body can we focus on, right? What are things you've never spent a lot of time thinking about because that's just not was something you were used to? So it's really kind of like a new course a little bit on the other side of this. And I do think it's important for folks to, wherever they are on this journey, to figure out kind of what your goals are. What is it that you want? What's important to you? How do I make a plan that's going to be helpful? What are the things that I want to work on? And most importantly, that there is absolutely support available for folks that are dealing with any of these changes, or for folks to talk to if you're worried about any of these changes, right? Again, being proactive is a very important part of this. So in summary, definitely feel that you can talk to your team. I definitely will also acknowledge that not all teams are equally comfortable talking about this stuff, but the good news, and certainly the years that I've been doing this work, is that we have a heck of a lot better resources now than we did 10 or 20 years ago. So whether that is even through the Force website, through many of the national organizations that are sort of cancer focused or survivorship focused or menopause focused, there's actually more information now than ever about sexual health, both after cancer, after risk reducing surgery. So please use the resources. The Dana-Farber has a lot of information on our website, as does Sloan Kettering. And I just want to say it's a pleasure to be here with you. I know I spoke a little quickly, but appreciate having the opportunity. Thank you.
Okay, that was an excellent talk. I'd say that as a urologist and a surgeon, most people come to see me for mechanicals issues. I try to get my patients to think about what Dr. Bober talked about today, and it's really, really hard. People want sex to be exactly the same way that it was when I was 15 years old. They want to do the exact same sexy moves they do at the beginning. They don't know how to do anything different. They think everything should be the same, and that's just not reality. So I really wish that before a patient would need to see me, they would have to watch your lecture first before they came. And the sad thing is that it's really, really tough. Sometimes, even though I'm a surgeon and a urologist, I sometimes really do think myself as a therapist more than 50% of my erectile dysfunction visits. And a lot of times I do recommend that my patients go to see a therapist or be able to talk about this, but they really, really just don't want to. So whether that happens to be you in the audience or whether you're supporting someone in the audience, please understand that. And the one thing that I would say is that also, a lot of times we say to ourselves or we say to our partners that, oh, you know what, say for example in a male standpoint, my patients, they want a penis implant to put in their penis so they can get their penis hard, just to be frank, okay? And then their wife says, oh, I love them. I love you. You don't need to do that for me. But sometimes it's not about what they're doing for you. Sometimes it's just where they need to be. So I tell them the opposite thing. Go home and tell your partner and say, if they had breast cancer and they wanted to have some reconstruction, you would tell them the exact same thing. So sometimes we need to see things from the other person's lens, not just in terms of kind of what we don't want them to do, what we're afraid for them to do, and things like that. So these are my disclosures. In terms of our discussion today, obviously we're going to talk a little bit more about prostate cancer and prostate cancer data, because that's what I do in the patients that I treat. But that is just an organ in the pelvis. A lot of you have a different organ in your pelvis, which you may be at risk for different issues for, so just extrapolate this in terms of kind of what you or your friends or your colleagues may be going through. But we know that radiation and surgery play a significant role in pelvic organ malignancies. Due to the close proximity of these organs in the pelvis, it makes them particularly vulnerable to any type of radiation or surgery-induced injuries. As a surgeon, we talk about these things clearly with our patients, but really at that moment, patients are really thinking about what am I supposed to choose in terms of how to allow myself to have the best duration of life. They're not always thinking about the quality of life at that time. So even though we as surgeons mention these things briefly, I don't think it's a fair setting for people to really fully comprehend what's going on. Fortunately, there's a decline in cancer-related deaths due to early detection, advancements in treatment techniques, as well as systemic therapies. However, what that means on the other side is that there's an increasing number of cancer survivors who are living with quality of life issues that were subsequent due to the therapy that they received. So you may think about sex and think about sexual. We need to think about the actual physical, talk about the actual activity of sex, but we're actually going to talk about urination first. And why? Because no one feels quite sexy if they are leaking urine. So this is a main issue for a lot of my patients, right? They don't want to even think about their erectile function until they can stop wearing a diaper. So even though you may not have undergone prostate cancer, women obviously experience urinary issues. And let's just talk about some of the basics, because when you understand how urination works, this helps you understand how your potential cancer treatments may affect the urination process and why you may have some subsequent symptoms. So we know the bladder stores urine. The bladder should store urine in a passive, elastic way. As your bladder fills up, you should not have the desire to go to the bathroom quickly, because that bladder should continue to fill up slowly. It should not contract. We call that overactivity of the bladder. We call that urgency of urination. As the bladder passes urine, and this is the male anatomy, the urine will go through the urethra, through the prostate, and there's a sphincter muscle that controls the urinary process so that you don't pee on yourself. Okay, we call that the urinary sphincter. And then the urine will pass through the urethra, out the penis, or out the meatus for a woman. So we can see here by understanding this that if someone undergoes surgery for their bladder, radiation to the bladder, surgery for the prostate, radiation to the prostate, whatnot, you can have injury to any of these areas. What people don't fully understand when they come to see me is they think that urinary problems means that they have prostate cancer, but that's not completely true at all. Many men with a large prostate have no urinary symptoms, but can have prostate cancer. Some patients with a small prostate can have lots of urinary symptoms and can have prostate cancer. So they're actually two different, completely different things. Whenever you get pelvic radiation, often the radiation oncologist is going to tell you, come with a full bladder. You cannot pee for 1 hour before you get it. So why exactly are they telling this to you? They're telling this to you so that the radiation beam, it will have a less burden on the bladder itself, okay? Even though they have focal MRI and MRI-directed, CT-directed, whatever, therapy, in order for that beam to get to that organ, it's going to pass through tissue around it. So the surrounding tissue receives secondary damage, and that secondary damage can cause change in urinary symptoms, cause strictures in the urethra, all sorts of different issues. And those type of things, fortunately, are not common, but those things happen, unfortunately, 10, 20 years after the patient has already received the treatment. So then they really feel burned. They say, no one told this to me. How can you remember what you were told 10 to 20 years ago? And they get radiation often because they feel good while they're getting it. They can play golf. They can do everything that they want. But they don't fully understand that the radiation damage is permanent and that often the damages can really manifest themselves 10 to 20 years down the line. So in terms of urinary symptoms, it can cause obstructive symptoms, urgency, frequency. It can cause even bleeding of the bladder. And what we're talking about today is urinary incontinence in detail. Urinary incontinence obviously is a major issue. A lot of my patients, they don't want to leave the house. They don't want to go sit on their friend's couch. They don't want to go to a restaurant. They're afraid of getting a wet spot on their pants. They don't want to go because they think they smell. They ask their wives or partners to carry extra pads in their purse. They got them in their pocket. They got them in their glove compartment. They got them all over the place. And when they travel on a trip, they have a separate suitcase for their pads. okay? So there's different types of incontinence, though, that can happen, and this is for all of you. Stress incontinence is when you have leakage with laughing, coughing, and sneezing. This is a problem with a physical defect, not having enough structural support that causes leakage. Urge, which can be enlarged prostate-related or radiation-related, means that you can't control your urine well. When you run to the bathroom, this is when you're running to the bathroom. This is you holding, your hands in between your legs. Some people have both issues. Some patients, they have functional incontinence. So maybe someone who's a little bit slow on a wheelchair or whatnot. They can't get to the bathroom in time, so they leak on the way. It's not that they can't control it. They just physically cannot get there in time. And then there's overflow, meaning that sometimes patients they actually can't empty their bladder well, so they're a full bucket. So every time they move, that full bucket gets kicked, and then therefore some urine comes out. So understanding that there's different types of incontinence is important. So typically when patients are diagnosed with prostate cancer, they have to make a decision. Am I going to watch this, if it's something watchable, or are they going to go surgery have their prostate removed, or are they going to go radiation therapy? These are quite small, but basically what it's saying is that with radical prostatectomy, yes, you have a higher risk of developing urinary leakage. And that makes people say, I don't want to have my prostate removed, I want to get it radiated. Okay, fine. Well, if you get your prostate radiated, there are other different types of urinary symptoms you can develop, such as frequency, and even waking up at night occurs greater because of the radiation changes to the bladder. So unfortunately, there's no exactly one way to win in terms of these type of therapies, but we try to best at least get our patients to understand what can be done. So in terms of stress incontinence, what are things that we can do? We can reduce the fluid amount that people intake. They basically dehydrate themselves. They go to the bathroom more frequently. They wear diapers, pads, clamps on their penis, but that's only sustainable for a few hours. There's Kegel exercises, which Dr. Bober mentioned. Yes, they're helpful, but often you really need to do them well, and you need to do them properly. The majority of people don't. So that's why physical pelvic floor therapists are a good source to teach you well and to be your coach, to motivate you, to make sure that you're doing them properly and that you continue to do them. If you look at the people who wear pads and undergarments and liners, if you change these pads about 5 times a day for about 5 years, this is several thousands and thousands of dollars that people incur. And many of our patients don't want to go to the grocery store or Walgreens or CVS to get them themselves. They make their partners go get it, right? They're just embarrassed. They don't want to be seen in that aisle. So I'm not saying that everyone needs to have a surgical treatment, but the good thing is that there are options that exist. So when patients come to see me, obviously I'm a surgeon, and I'm not saying that they need to have a treatment, but I want them at least to learn what they could do. Because if you're at home not knowing what you could do, that's a very different story. And if you come to see me in clinic and say, hey doc, I don't need any of that, then that's fine. That's a choice that you made. It's not a choice that you just stayed at home and weren't able to learn more about. But there are ways that we can treat incontinence. There are slings that we can do. There's artificial urinary sphincters that can be performed as well. There are options out there. And I would say that, we'll skip some of these. I'll say that in terms of knowing about options, when you see your doctor or your partner sees your doctor, that doesn't mean that that doctor has to be your doctor for life, okay? Sometimes many patients think that that's true. This is my doctor. What he or she or they say is biblical. Often some of these doctors, they actually don't quite care about what you're talking about. They actually are not very interested in how dry your vagina may be. They may not be very interested in how well your erection works. That's just fact, okay? They may not know what to deal with it. They may not know who to send you to. So sometimes you have to advocate for yourself and come to conferences like this to learn more about that. But essentially, there's nothing wrong with getting a second opinion for something that you're eager and interested in learning more about, okay? Your one doctor doesn't need to be your doctor for life. So in terms of sexual dysfunction, there's many types of parts of sexual dysfunction. When we talk about ejaculatory dysfunction, there could be the inability to ejaculate at all. There can be climacturia, so when orgasm is achieved, actually, urine comes out. There could be an inability to reach orgasm, and many people get confused. Orgasm and ejaculation are actually different entities. But understanding what somebody is bothered by is very important because there are different treatment options. Some patients after cancer treatment can develop painful ejaculation, premature ejaculation, delayed ejaculation, or delayed orgasm. So we know that patients who undergo surgery, that's what a radical assisted laparoscopic prostatectomy, or RALP is, have significant changes in their erection. And so can patients who undergo radiation therapy. Why does radiation therapy and surgery cause changes in erectile function? Because it can injure nerves. It can injure blood vessels, and it can injure muscles. Whenever someone wants to feel sexy and wants to get an erection, the brain needs to send a signal. That's through the nerves. So it needs to send a signal to the nerves to say, tell those blood vessels to open up so that the blood can flow into the penis. That helps it give an erection. However, many people say, Doc, blood goes in, but that thing doesn't last very long. Why? Well, the blood needs to stay inside to be able to maintain an erection. So you need all three of those, and that's why surgery and radiation can cause injury to these areas. So basically, this is the same type of slide except for erectile dysfunction rather than urinary incontinence, that you can have sexual dysfunction with either therapy, yes, maybe a little bit higher with radical prostatectomy. So why is ED important? Because it really affects quality of life, as Dr. Bober talked about. It has broad implications. A lot of patients, unfortunately, come to see me and they think that it's the reason why their marriage is lost. So they come to me to get their erections better because they don't want their partner to leave them. Well, I actually tell them that their partner's probably going to leave them anyways, unless they find some other type of way to work on it, such as therapy, counseling, and things like that. They have to think more in depth, but it's not easy to do that, as we all know. So it's important to know what treatment options exist for erectile dysfunction, talking about the mechanics here, okay? But I really try to get my patients to know what options exist so that they can stay away from things that are less beneficial online. As we talked about CO2 laser, there are also equivalent types of products that exist for men, shockwave therapy, platelet-rich therapy, stem cell therapy, and there's a lot of people who are being charged thousands and thousands and thousands of dollars for a treatment that really has no data to support its use. So I at least try to get my patients to know what really could exist. Even though they may not like any of these, at least they know what they could do. And sometimes it's not about like. Sometimes it's about need. And nobody comes to me saying, Doc, give me a penis implant today. I've done that twice in my career. What do you think both of those people did? They canceled their surgery because they weren't ready, okay? So really, everyone has their own journey that they go through these type of issues, whether it be from cervical cancer, breast cancer, whatever it may be. It's a journey. Don't expect that you're going to find all the answers at one time, because often what you hear the first time sounds crazy. And then you go home and think about it a little bit more, and you're like, oh, that wasn't that bad. Then you learn a little bit more, and then you find out, what do I want in my life? And then you say, hey, I'm ready for that. I'm ready to try this. I'm ready to try that. And that's normal, okay? Nobody comes in here guns blazing. No, that's not normal. So we know that there's oral medicines for erectile dysfunction. These are medicines, Levitra, Cialis, so forth. They all have the same mechanism. So you don't need to take all of them to try all of them to see if all of them don't work, okay? Just one or two, that's enough. But you do need to take them properly. There are rules in how you should take these. Then this may be helpful for everybody. But in general, these medicines need to be taken about 1 to 2 hours before sexual activity. They don't stay in your body forever. They only stay in your body for about 8 to 12 hours, and they do require physical stimulation. So if you or your partner takes these at 8 in the morning and try to have sex at 10 o'clock at night, that sucker ain't in your body anymore, right? And just because you try it one time doesn't mean that it didn't work. There's variations in terms of what you eat, how you feel, how sexy you felt. Were you tired? Were you mad? Were you angry? Did you want it? Or were you just trying to do a service? You know, all of those things. So you really need to try these type of things 5 to 6 times at least to make sure they are or are not working. However, the problem with sometimes medicines is that they can help. Oh, well, my penis became a little bit full, but that doesn't mean that it worked to where the person needs it to be. Very, very different stories. So unfortunately, although many people have a response to oral medicines, they're not sufficient in helping to get them where they want to be. I'd say in terms of this, a lot of patients have very, very expensive medicines to take. There are ways now to learn about which Medicare plans are best for certain types of medicines. I can't remember the website, but you can look at these so that you can adjust your secondary plan so you get the right plan to cover the medicines that you want. There are lots of other ways to pay out of pocket, even though you pay for your insurance and you think it should cover everything that you want. Sometimes it's just frankly cheaper to just pay out of pocket. Mark Cuban has an excellent pharmacy where you can even get your basic drugs for dirt cheap. Now Amazon has these services and so forth. So going out of the traditional realm can be positive. Vacuum erection device. This is real. You may have heard this in Austin Powers, but it's real, okay? This is a cylinder that you can place over the penis. It applies a suction to bring blood into the penis, and then basically a rubber band type of device that goes on the base of the penis. Kind of a mechanical way to develop an erection. What I tell my patients is that if you are interested in trying this type of device, you need to take a deep breath before you open up this box. After you open that box up, you need to take another deep breath. Before you put this thing on your penis, you take a third deep breath. And you need to be patient with yourself, right? You can imagine that the patient may not feel very masculine when they open up this product. They may not feel very confident. And if it works, what do you think they do? They put this thing underneath their cabinet and throw it away and say a lot of nasty words and say, why did I spend that money? So we need patience, and we need to teach our patients proper expectations. Hey, this ain't gonna work for you the first 5 to 6 times. And that's okay, but at least as they know that, then they can try to be successful the 7th, 8th, and 9th, and 10th time. Urethral suppositories, these are medicines that really don't exist as much anymore. In my opinion, if you're willing to put a pellet down your urinary tube of the head of your penis, you're probably more willing to do injections of the penis, which are a lot more controlled. Injections of the penis, this is not a like one and done type of deal. It's not a cure. You need to do injections each and every time that you want to have sexual activity. Penile implants, I do a ton of these. It just happens to be kind of what my interest is and what my research interests are and so forth. But this is a mechanical way to develop an erection, very similar to what I'd say a hip replacement or a knee replacement. Yes, for some people, sexual activity is not important enough for them that they want to have a surgery. Great. Inject your penis. Well, doc, I don't want to inject my penis. Fine, don't inject your penis. Use a vacuum pump. I don't want to use a vacuum pump. Okay, fine. Read some books, So at least they can understand. But unfortunately, there are not unlimited opportunities that exist, right? There are a finite number of options that are real, and they just need to kind of decide which of them works for them, okay? And in terms of surgery, I definitely tell my patients, you cannot surprise anybody with this. People who surprise their partners with this, it's not a good surprise, okay? So the last thing that I'd like to talk about is in terms of hormones, right? In terms of menopause, men can go through a similar type of menopause due to low testosterone. That can be something that they just experience on their own. It can also be something that is induced with medications, such as with metastatic prostate cancer therapy, or for patients who are going high-risk radiation therapy. So these can cause the same things that menopause can. They can cause changes in libido, depression, change in mood, characteristics of the body, hot flashes, and so forth. But this is real, okay? So as you can see on the right, the orange is patients who only get radiation. In the blue and the green are intermediate and high-risk patients who get radiation plus hormone therapy. We know that radiation is good. We know that hormone therapy reduces the activity of prostate cancer cells. When you combine them together, they work better together. So that's why it's utilized. Fortunately, for most of these patients, they may need the hormone therapy only for maybe about 6. Some patients need it for maybe even 1 to 2 years, just depending on the degree of the disease that they have. But this basically turns the testosterone into single-digit numbers, so extremely, extremely low. So the idea 20 to 30 years ago was that if somebody has prostate cancer and they have low testosterone, and we know that testosterone feeds prostate cancer, there's no way we should give those patients testosterone at all. But walking around are plenty of thousands and tens of thousands and hundreds of thousands of people who have prostate cancer who have a normal testosterone. So what's wrong with giving the people with low testosterone so they get to a normal level? So unfortunately, sometimes we're very, very cautious about medicine at the beginning, and then sometimes it just takes decades for us to just actually think about things and, change our mind in terms of what's going on. I don't know kind of what they're thinking in terms of women's health and women's cancer, but we know that for patients who have atrophy of the vagina, if you have a hormone positive HER2, for example, or BRCA type mutation, the current teaching is you should not get any hormones onto your vagina. I don't know the data to that. Maybe Dr. Bober can comment on that later, but maybe that similar type of thought process is changing. And what's wrong with putting someone to a normal level? I don't know. So in terms of this has changed, and this is changing. We don't have a lot of excellent guidelines dictating this. A lot of the societies that work in men's health have given broad guidelines. Similar probably in women's health, there's no randomized trials to support the use of giving testosterone therapy in prostate cancer patients. There are a lot of retrospective studies. Fortunately, none of these studies show that there's any increased risk in the PSA coming back, which is what we call a biochemical recurrence. There's even some studies that show that men who have very, very low levels of testosterone have very aggressive types of prostate cancer. So at Johns Hopkins, for example, they have a study where they actually try to confuse the cancer. For patients who have this type of cancer, they give them medicine to make the testosterone zero, to make the cancer slow. Then they actually give supratherapeutic, giant levels of testosterone to then feed it, and then they shut it off, on and off, on and off. Because what happens is that if the cancer gets used to a certain environment, it will learn how to go around it. And that's what we call hormone, basically cancer that has developed a way around the hormone pathway. And if we do give testosterone to our patients who have a diagnosis of prostate cancer, we obviously need to understand and talk to them that they have a risk that's not fully understood, and maybe we should be careful for patients who have really significant disease. So this is kind of my last slide for this talk, and I think we as physicians and we need to do a better job in terms of setting the right expectations. As Dr. Bober mentioned in her presentation, we need better literature to be able to, and guides so that people who are deciding between treatment options can really understand what can happen. Just verbally hearing about a side effect one time or two times is probably not enough, right? It's just going in 1 year and out the other year. But this is a study that looked at patients who were treated with prostate cancer and asked them, what were your expectations in terms of your sexual function? When they queried these patients, the patients expected that they would be able to recover their erectile function at a much shorter time than actually it took. They were unaware that they would lose the ability to ejaculate. They didn't know that all of that fluid comes from the prostate and the seminal vesicles, which is removed or radiated during radiation. What patients often think about is that, oh, doc told me I'm going to get better. But that's not what you really want to know. You want to know how much am I going to get better and when am I going to get better. So when we tell patients, don't worry, you just wait a year, that's when most people get better. They think that they're going to get back to how they used to be before surgery. But the number of people who get back to where they used to be before surgery in terms of their erectile function is about 20%, pretty darn low, okay? They're unaware that their penis is going to become shorter when they get their prostate removed. They're unaware that the number of patients who actually need injections after surgery. And they were unaware that you could develop a curved penis after surgery. And this could easily be 6 lines on a document that someone could easily learn about the changes in sexual function with prostate cancer treatment. And although we're talking about prostate cancer, this applies to any type of cancer, right? Any type of cancer should have a type of easy-to-read pamphlet in terms of what are the benefits and negatives and what are the potential consequences that a large number of patients are going to feel. So in conclusion, radiation and surgical therapy have significant, I don't even know what that means, have significant impacts on urinary and sexual health. See, I'm always thinking about surgery, so I even wrote implant in there in the first line. We know that side effects can occur acutely during the treatment, but really can also affect us for decades after the treatment has occurred. We need to improve patient decision-making materials, and we need to consider helping our patients get to the right place when the patient is interested and when they want to. In the urology field, a lot of the time, the people who are doing these surgeries classically are reluctant to kind of give up their patients to other providers. They may not want to know how many of their patients actually leak urine, right? Because they're getting referrals from other people. They may not want their colleagues in the community to know how many of their patients that they perform surgery on actually are getting significant erectile dysfunction. So there's a lot of competing interests here. So as patients, we need to be empowered ourselves and find out the information that we're looking for. So thank you.
All right. That was incredibly educational from both of our speakers, so thank you. If you have a question, I'll try to get both sides of the room. And again, if we can have the doctors, when they respond, to please speak into the microphone, that would be really helpful for the recording.
Thank you. Hi, I'm Debbie. I'm from New York. I'm BRCA1 positive, triple negative, diagnosed 27 years ago. Doing good. But not doing good there. I work with my gynecologist in having an E string or S string inserted in my vagina every 3 months. He puts it in and takes it out, puts it in, takes it out, and so on and so forth. And mainly that helps with vaginal dryness, but it does not help with sexual desire.
Right.
And that's where I'm at right now.
Is that the short question?
And I love my husband very much.
Okay, I
So
hear
that has to qualify.
Yeah. So I would just say that, I think, as you probably got a sense from my talk, that I think desire is often like a recipe with many different ingredients, right? There are different pieces to that. And I think that the one thing which I didn't say, which I think is, I probably should have, and I'm happy to have an opportunity to say it now. Most of the time we understand what desire is based on like what we see on like Bridgerton or on, based on like how it was when we were 20 or as you said, when we were, 18 years old. The thing that is never talked about, but that is absolutely almost universal, is that for most people, desire shifts from being a kind of an automatic, spontaneous thing like a light switch to an experience that you have to cultivate, right? It does not maintain the sense of just being automatic, like thunderbolt out of the blue over the lifetime. That's for sure the case for most women. And by the time we get to midlife and beyond, with or without cancer, menopause typically, where we don't have these sort of hormonal fluctuations anymore, desire is not spontaneous. And I would just say that by itself is not a problem. The issue is that people really have to learn strategies to have a repertoire for how to have an experience that allows you to jumpstart that experience, right? That allows you to have an experience that is pleasurable or romantic, that allows you to build an experience. I think of it a lot like exercise, right? Like my alarm goes off 3 times a week at 5:30 in the morning for me to go to the gym to lift weights. I do not want to do that most of the time, especially in Boston when it's like really dark and cold. And inevitably, I go because it's a priority to go, and I always feel better when I'm there. And that is what allows me to be motivated to do it the next time. But if I were to wait for me to be spontaneously motivated to do that, in the middle of February at 5:30 in the morning, I would never get up. So I'm not saying that's exactly relevant for you, but I would just say in general, when I think about desire, when people say I don't have any desire, it's really important to set the expectations that I don't assume it's going to be spontaneous, right? But that it's more about saying, what can I do with intention, right, to build an experience, and when you have a partner that you're connected to be able to figure that out together, so that you can, create an experience that allows you to feel closer, to feel more connected, to have an experience that's pleasurable, to not feel pressured. And it's really sort of creating an experience. It's not about whether you have it or whether you don't. It's a very short answer, but just to give some background. Yeah.
I'd just say one comment in regard to that. I'd say that both sides are probably scared to talk about it. Okay, and it's not easy for either side to come to the middle and bridge that gap. And I think sometimes when we acknowledge that and we meet halfway, then the other person can be thankful that someone at least initiated it, because it's like the first time you want to kiss somebody, you're like, oh, is he going to do it? Is she going to do it? What's going to happen? You know what I mean? It's like that, and sometimes someone just needs to try to just initiate and have that conversation. And I think conversations is better than trying to initiate physical activity first.
But your point,
Yeah.
and I think your point, Dr. Chung's point is important, because I want to just underscore, his point is that there has to be intention, right? You have to choose to have a conversation, to talk about something that maybe is hard to talk about, right? That you may be avoiding by not talking about it, even though you may be very connected and feel very close, right? It's not intuitive. So being able to say, gosh, this is something that's been on my mind, it's something that I'm thinking a lot about, and I just want to say most people cannot go from 0 to 60 in 10 seconds, right? We're talking about a kind of a slow, intentional experience where you sort of build experience that feels pleasurable, that doesn't feel pressured, and that allows you to sort of experiment together to figure out what feels okay. It's not about you have it or you don't. That's not a great setup. Yeah.
And then as you're getting the next question, you just have to also make sure that you're on the same page, right? Maybe you think, I'm not saying you, I'm saying, maybe, people think that their partner wants it or wants it as frequently or whatever it may be, or you think the partner has crazy expectations, but that's not always true either, right? So at least getting on the same page can provide comfort to both parties so they can be more happy.
Hi, my name is Brianna. I'm BRCA1 positive. I'm also a breast cancer survivor as well as cervical cancer. I know this isn't about cervical cancer or anything, but I do see a pelvic floor physical therapist, and there's been some recommendations from her, but I was kind of wondering, I have kind of two-part question, but what are your thoughts on using dilators versus like just having sex with penetration? And then the second one is, what are your thoughts on like a TENS machine for the urinary issues? So that might.
So say the urinary question again. What's the part 2 of that?
The TENS machine, a TENS machine.
Yeah, I'm not familiar if there's any data that shows whether a TENS can be helpful or not. I'd say that in terms of urinary issues, as we kind of talked about enlarged prostate, sometimes it's very important to understand why you have the urinary issue and what the urinary issue is. A lot of people think that just because pee is coming out of their penis or their urethra, that they're peeing okay. But that's not 100% true. When you talk with a urologist, and maybe you have already, there's like 15 questions I ask about how someone pees, Just because I can jump doesn't mean that I can dunk, right? So sometimes you have to understand what your exact symptom is, because say, for example, if you have a tight pelvic floor and you're trying to do pelvic floor therapy, well, for further strengthening, that's not actually what you should be doing, right? You don't need to strengthen it. As a young person, it's probably already strong enough. You're just making that sucker more tight. So sometimes it's even more about relaxation. So, the question is, and I don't know the answer, does a TENS machine relax or does it tighten, right? And those are the things that you kind of need to understand. The good thing is probably the TENS ain't gonna hurt you, right? So it's a easy thing you can buy on Amazon and try and see how it works type of deal, not much loss besides $50, safe to use. But I think you need to know a little bit more in detail about what you're actually trying to improve in terms of your urinary symptoms.
Yeah, that's right. Yeah, no, that totally makes sense to me. I would say that the question about penis or dilator, just to cut to the chase. I would say this, I don't think it's a good idea to be doing sex in a kind of therapeutic way if it hurts, right? I think that's the big problem, the big risk with that is that if you're trying to like have intercourse because you're telling yourself, it's like military campaign, I need to do this in order to make sure that my vagina is healthy, I think you really run the risk of this little then all of a sudden you're pairing, intercourse with other things, right? Discomfort, is it particularly pleasurable if you have to do it? So, my feeling is that, it totally makes sense, and if you need to be using dilators in a regular way in order to keep that vaginal tissue open and stretchy and have vaginal capacity, I think once you can have intercourse comfortably and it's pleasurable, the question is, can you be doing that instead of using your dilators? And absolutely, there's no reason why you need to be doing both. But the point is, what I wouldn't say is that unless intercourse is comfortable and pleasurable, I wouldn't be sort of forcing yourself to do that in lieu of dilators. Does that make sense? Because then, then it's complicated in terms of how excited you want to be to do that, and then you sort of have those associations. But I think the point is that if you get to the point using your dilators that you're able to have intercourse comfortably and you want to do that regularly, there's no reason why you need to continue using your dilators if you're getting that intercourse, if you're having that sort of movement through sexual activity.
Hi, Paul Monk, infiltrating here. I'm a medical oncologist, and you guys are giving great talks. This is excellent. Dr. Bober, in my practice, I treat mostly men, and they are not quick to talk about sexual dysfunction at all. If they mention anything, then I jump on them and I send them. But I wonder, in your shop, do you guys proactively send guys for counseling? Because I think if people heard what you are giving, we would probably address a lot. And then for Dr. Chung, excellent talk as well. In times past, we talked about something called penile rehab. So in the midst of their 6 months to 2 years of ADT radiation, or right after prostatectomy, we talked about, well, maybe give them Cialis and a pump. Is there any data that penile rehab, while you're waiting for the testosterone to come back, is there any data now that says that helps?
You want to take that? Okay, why don't you take that? Anyway, yes, you're an oncologist? Is that what you, yeah. So I think within the sexual medicine world, put it this way, there is some data about penile rehab. A lot of that data is still in like mouse models. I don't think we have there's limited data in terms of, prospective studies of penile rehab. But that being said, I think that most urologists who are doing sexual medicine after cancer are very regularly saying it makes sense that you want to get that endothelial tissue suffused with oxygenated blood flow. Tell me if I'm wrong, Paul. But that there's a lot of reason why it conceptually would make sense to be trying to get as much blood flow to that tissue as you can, because you're going to have atrophy to muscle, right? If you're not going to have any natural blood flow there, if you're not having any erectile tissue activity. So, I think the question is, how much data do we know is convincing everyone should be on that? I don't think we have that. But, certainly if you go to the, Sexual Medicine Society of North America and, John Mulhall's, shop at Sloan Kettering, this is what they say is standard fare, that everybody should be doing penile rehabilitation, that everybody should be on a PDI inhibitor, certainly, on the other side of these treatments, and that if that doesn't work within 6 months, you should be doing ICI. That the idea of just waiting for 2 years and doing nothing, actually has potential to be really problematic in terms of potential atrophy. I'm just pretending to be a urologist here. Am I getting that right, Paul? Okay, yeah, he's nodding, so I'm going to keep going with that. But yeah, so I think that's something that we talk about a lot. And I would also just say that, this idea of not talking about it with men, I think that we often say like men just want to talk about the mechanics. I'm not actually sure that's true. I think that we live in a culture that's like so super focused on erectile function. People just assume that's all they're supposed to be talking about. But like, I really appreciated what Dr. Chung was talking about today in terms of giving people the opportunity, the space to sort of open up that conversation. I see a lot of men, and it is not only just about the mechanics. The fact is people feel very damaged. People have all kinds of assumptions about what their partners assume, you know. And I think if we can kind of normalize the fact that this just affects partners, as it's a couples issue as much as it's an individual issue, you know. So I think there's room here for all people to be able to sort of engage in some of this conversation as a whole person, not only just in terms of the mechanics. But I you know, it's an interesting question about what is the evidence. We have some, but I don't think it's not gold standard that everybody gets put on penile rehab therapy, but more and more urologists are definitely moving in that direction. I will say that. So, is that?
Yeah, I'd say all of that is correct. I'd say that, at least in my thoughts and kind of how I practice, it's less about trying, in my opinion, trying to improve their erections in the long run and make them better by doing the therapy. I think it's more about just allowing them to resume their sexual activity earlier and getting them to talk about it and focus on it. Because a lot of patients, they say, hey doc, I'm just gonna see how I am in 2 years. I'm not even gonna try for 2 years. Well, why? Why not start earlier? So I do it from more that standpoint because the data is not that strong showing that it's gonna make their erections 10 out of 10 in 2 years.
But that's actually I think a super good point, which is that it goes back to the avoidance thing, right? When people are like, I'm just not going to do anything and I'll deal with this in 2 years. You know, if you have 2 years, and that's the case whether it's a woman on an aromatase inhibitor after breast cancer or prostate cancer, where you just say years go by and you just sort of table everything around intimacy, it's really hard to kind of figure out how to reconnect, you know, when literally years go by. And I think like being able to sort of support people to have ways to be connected and intimate with partners, whether it involves intercourse or not, that is not the goal. I think it's actually incredibly helpful so that it doesn't feel like there's just this huge chasm of space in between, but that people have been able to sort of have a kind of an intimate sexual life with or without intercourse in this time where they are in recovery or in survivorship or whatever.
All right, I think we have time for one more question if anyone has one they'd like to ask.
Thank you for a really informative and very interesting presentation. I'm just wondering what you had said just before in terms of it's hard to tell about the status of your pelvic floor. So is there anything quick you can tell us in terms of assessing ourselves if it's too tight, if it's looser? Like, how do you know?
You want to take some of that, or you want me to, you just, okay, Dr. Chung, thank you. So I think that, you know, the bottom line is that for women, let's see, broadly speaking, you know, if you're peeing when you're coughing or sneezing or jumping, you know, and you don't want to be peeing, that's the pelvic floor issue, right? So that's one thing. If you're having intercourse and it is uncomfortable and or hurts, and it is not because of dryness alone, that's a you know, hint that maybe that the pelvic floor is too tight, right? There's discomfort. Not everybody has, like, you're not like you walk around knowing what your pelvic floor is doing. So I don't think that it's something that it's necessarily good or bad, you know, but I would say that in terms of symptoms, would you say those are the, you know, sort of urinary symptoms that are bothersome, you know, is one piece. And then usually the other piece has to do with any kind of pain or discomfort with sexual activity over and beyond, you know, dryness per se. So those would be the sort of two sort of main things I would think about. Is there anything else you would?
No, the only thing that I'll say to give you all some hope in the field of medicine is that when I trained and finished my training about 8 years ago, this idea of GU menopause and talking about sexual activity, pelvic floor, you know, dryness of the vagina was really, really, really minimal. So I would like us all to at least be excited that there are people who are now training in this, focusing on this. There's research in this. When you go to the Sexual Medicine Society or even this regular urology meetings, these are conversations that are being had. So I do think this is an exciting area of medicine, and a lot of improvement is happening. And the goal would be that you don't have to come here to learn about this, and that your providers in in a couple of years will be able to know all these things and be able to help you with all of these things at home or at wherever you like to seek care. Obviously, that will take time, but that is the future.
Thank you. Just a quick follow-up in terms of the bladder control then. If you have bladder issues, then that means the pelvic floor is weaker or not tight enough. It's the opposite.
You take that, my friend.
Well, I think when we talked about the different types of incontinence, right, it's very complex. People think that just because they're leaking urine, it has to be from a weak pelvic floor. And on that slide, I showed you 5 to 6 types of incontinence. So it's much more complex than just pelvic floor. So I think that's why before seeing someone who's interested in helping you with those type of symptoms is important, because there's many people who don't quite care about those symptoms that you just described.
It's just to say, I mean,
Yeah.
there are urogynecologists, so there's actually a whole subspecialty of folks who sort of are at the intersection of urology and gynecology, and they actually sort of have certification in urogynecology, and there are folks that can help you figure that out if that's something that you're struggling with.
And then the second thing that I would say is, if anyone ever seeks care in these type of issues, just think about a little bit about what you're experiencing. Try to come up with a little bit of a pattern. Try to just have a little bit idea of why this may be occurring for you and what you're experiencing. That will just help to make your first visit a lot easier, because you're coming with information that you can provide. When patients show up and they say, "Oh, I got a problem, I'm not happy with how I pee." Great. Well, you're probably not going to get a good visit out of that. And then you're going to feel like, oh, that person didn't help me, and then therefore you may not want to seek care again. So often if you come with a little bit more preparation, then I'm not excusing the physician. I'm just saying it just helps with the visit.
Thank you so much. Let's give Dr. Sharon Bober and Dr. Paul Chung a round of applause.